BTK inhibitors are an outstanding class of drugs. There are many patients that benefit, and where I am in Central Ohio, we have patients where convenience really matters, because I see a lot of patients from the country that have trouble getting to Columbus, Ohio, and to them it's a big city. I grew up in suburban Chicago, so I don't feel that way about it. But BTK inhibitors are convenient, have less visits, are highly effective. So this is a good treatment strategy, but the cardiac toxicity has really been a concern, especially for patients that already have risk factors for things like atrial fibrillation, like they've had it in the past, they have hypertension already, things like that. I think the best strategy we have so far has been to use the newer covalent BTK inhibitors, Acalabrutinib and Zanubrutinib, with both have lower rates of atrial fibrillation than the first-in-class drug, Ibrutinib. So I think selecting that one up front will help the patients experience less cardiac toxicity kind of as a group. So I think that has been probably the most helpful. Although we reported, actually we're involved in some research showing that there does appear to be an increased risk of ventricular arrhythmias even with Acalabrutinib. And while we haven't shown it, I strongly suspect that we'll see some increased risk over the population risk with Xanu too. So I do think there is some class effect with this. So I don't think we've really minimized the cardiac risk to be like nil, but I do think this reduction helps. And I think that some of the strategies we're seeing now, where we have fixed duration BTK inhibitor like venetoclax or BCL2 inhibitor combinations, will also help limit cardiovascular toxicity, because we do see the cumulative incidence of that increases as patients continue on the drug. So a strategy where their exposure to the drug is less will minimize things that you see years into treatment with a continuous dosing strategy. So I think those are really the best options. The only other thing that kind of makes sense, but I haven't seen a high amount of data on, is just the usual cardiovascular risk modification that we see, but the evidence is not really in this population of people taking BTK inhibitors. It's really in adults that don't have CLL and aren't taking targeted oncology drugs. But we do know a lot about blood pressure management, like things that help reduce cardiovascular risk in general, statin usage if appropriate. So while I don't know that there's a lot of prospective data that aggressive cardiovascular risk modification makes these BTK inhibitors safer, I do think that, based on other evidence, I would recommend that for anyone that has cardiovascular risk factors.